Yeah, sure.
So we hand it over to you guys, and we'll put everyone on mute.
Yes, I think welcome to everybody being here. My name is Jacques Lloyd. I'm from. Sorry, just first of all, can everybody hear me?
Yes.
Okay, so my name is Jacques Lloyd. I'm from the National Department of Health in South Africa, and I, together with you, Niraj, started and planned this program, and yeah, thank you very much for everybody attending. And if you can introduce yourselves, I'm going to get Marissa a chance to introduce herself. She's one of the facilitators. And then if everybody else can just introduce themselves.
Hi, my name is Marisa Kutsia. I am currently a senior research assistant at the Department of Health and Rehabilitation Sciences at Stellenbosch University. I am a physiotherapist, and I've been part of this team working on getting this clinical guidance or this tool developed. Yes, so that's my background. I am also currently a PhD student.
Thanks, Marissa. All right, please go ahead, start.
All right, so.
Yes, just for those who do not have a background in what we are doing today is one of I'm a person with a spinal cord injury, and one of the things that I have picked up in the rural areas in South Africa was the fact that there was such a lot of people with spinal cord injuries as a result of spinal tuberculosis. And after this, we negotiated, and then we started developing this program. We did a emphasis study to look at what is the impact and where impact across the globe when it comes to spinal cord injuries as a result of spinal TB, and then designed this short course to give everybody the opportunity to be able to look at the early identification of spinal TB. We found that obviously the earlier you can identify it, the better the recovery rate, but also look at the challenges with regards to the early identification. There are various issues which the facilitators will discuss with you now regarding the challenges and looking at the indicators that are present to identify TB spine. So I'm going to give over, and then we'll just go through what the findings were, and then look at the program.
Okay. Dr. Nasib Tawa, can you hear us, and are you there?
I'm not sure if...
Yeah, so because I just would like him to also just introduce himself, but otherwise we can go on.
Just go ahead. I think he is online, but I cannot see him.
Okay.
I cannot hear him, yes. But his mic is open, so yes.
Oh, all right. So I'll continue, and then we can maybe just also allow him to introduce himself. Okay, so yes. I'm just trying to get the... Oh, there we go. So for this webinar, we'll have a quick overview on what is spinal TB and just the most important aspects thereof. I thought this would be important just to lay the groundwork for why we needed to develop the tool and what you will see in the early decision-making tool. Then we'll talk about the spinal TB review we did and the development of the tool. And then we'll have some clinical cases for demonstrating how the tool is used. And then we'll quickly talk about the publication. This article with the clinical decision-making tool was published earlier this week. So we'll quickly have a look at that as well. So just an overview and recap, this picture that you are seeing right here now was taken in the Eastern Cape. These two little boys in wheelchairs. The one was born with spina bifida and was in a wheelchair, obviously, since the beginning of his mobility. However, the other little boy developed spinal TB and had to be, mobilized in a wheelchair. And he was not too keen on using the wheelchair at first. So what they decided was, the clinicians there, they decided to put these two boys together so that the one boy can teach the other one how to use the wheelchair. And it was a major success, and they bonded very much over this. So yeah, why do we need to focus on spinal TB? Spinal TB is the most prevalent or the most common form of extrapulmonary TB. And it is in rise in the most African countries. It is the most prevalent opportunistic disease of HIV-related opportunistic disease at 54%. And yeah, a lot of the clinical signs develop, or the disease develop actually without actually having early signs and symptoms that's prominent. So the clinical challenge is, of course, that there's an insidious nature of the disease with a delayed diagnosis, because the patients develop this and maybe 3 to 4 months already have the disease, but do not show any physical signs and are therefore not consulting with their primary healthcare facility, and therefore have poor outcomes, because by the time they get there, they already have developed neurological signs. So the available solution was to develop a multidisciplinary team, develop a best evidence model to help guide the early diagnosis and of this disease. So who should be trained? Actually, everybody should be trained in this, especially the people at the primary healthcare facilities, the clinical nurses, the medical officers, physios, home-based carers. Yes, everybody should be trained in how to use this and how to just identify this disease early on. So in Africa, the early detection challenges actually lies within the lack of resources we have at a primary healthcare level. So we don't have MRIs and other investigative equipment. And there is a lack of knowledge, unfortunately, from the community and the primary healthcare staff. There's poor access to transport to visit the clinics. And there's some poor compliance to TB treatment as well. So these two photos you see here are the Eastern Cape, or taken in the Eastern Cape, the very rural Eastern Cape. So this village is very far from the nearest primary healthcare facility, and the road to travel to the facility is not wheelchair friendly and not really disability friendly. So these people have to pay for transport that's not cheap to get to the primary healthcare facility to have a look at what is going on. So the access to transport is a big problem in these areas, the very remote and rural areas. Okay, so just a quick overview on the pathophysiology. So the TB causes necrosis in the affected tissue, which forms a cold abscess. So this might be one of the very early signs. Well, it's not very early, but it's one of the more physical signs that you might be able to see early on. And then spinal TB infection is usually in adults from a primary site, such as in the lungs or the lymph nodes, gastrointestinal or urogenital system. In children, it can actually primarily originate from the disc in the spine, as it is more vascularized than in adults. But in an adult, where it is mostly, or it's always secondary, you need to be suspicious of any person who has TB in any primary site in their body, because it might actually spread to the spine. So the infection can spread up and down in the vertebral column. It's commonly seen in the upper lumbar and lower thoracic areas, especially the thoracolumbar junction. More than one vertebra is typically involved, and this is what results in the deformities that you see in these patients. Yeah, and it spreads through the blood vessels into the vasculature of the spine, in the bodies, the vertebral body, the disc, the longitudinal ligaments, all the support structures in this area. And if this is compromised, it will lead to subluxation and dislocation for these patients. So the 5 key components for early diagnosis, so how we can aid the early diagnostic process, is you must first do an associated fracture assessment for spinal TB, and then an assessment for common signs and symptoms. You must flag any significant findings on your physical assessment, flag any neurological findings, and then flag obviously any laboratory findings. So the clinical presentation, the symptoms, it is very varied, so there's no recipe really, there's no way to say these are the things that you will definitely be looking at. But back pain is the earliest, most common symptom, then followed by more constitutional symptoms, the fever, weight loss, and then of course any neurological complaints. But by that time, the disease is usually quite progressed. So back pain, the most common characteristics of the back pain specifically is the fact that it's insidious in nature. So a gradual and subtle onset, the patient will tell you, well, this started, I don't know why, I don't know what happened, but it just gradually got worse. It's not mechanical in nature, and it's mostly localized to the site of involvement. So the patient is usually able to show you with one finger where the pain is, rather than using his entire hand. So that is just the more common characteristics of the back pain that these patients experience. And then the neurological complications is usually associated with the epidural abscess. And if it's left untreated, the early neurological involvement may obviously then progress to more complete para or tetraplegia. The early onset paraplegia usually develops in the active stages of spinal TB, but you can also have late onset paraplegia, which can develop up to 2 to 3 decades after the active stage. And this is more noticeable with the very distinct spinal deformities. In South Africa, we have almost every second person with spinal TB that presents with paresis and paraplegia when they actually attend the primary healthcare clinic. And then lastly, the symptoms that the patient might experience is constitutional symptoms. So your usual pulmonary TB symptoms such as fever and weight loss, but those were the 2 most common ones found in the spinal TB, but there might be some night sweats, coughing, and general malaise. And then when you do your physical examination, once again, no specific single test that will tell you this is spinal TB. You must differentiate between spinal TB and obviously any other causes. So first of all, you will look for any spinal deformity, any cold abscess, such as the buoy at the bottom. So when you find something like that anywhere along the spine or in the groin area, you must investigate further. Yeah, you look for spinal deformity in any way. So it can be like an angular deformity in the spine, or such as this little boy here, where you can see he's got a bit of a scoliosis type of posture. Then you must feel along the spine, feel for any paraspinal tenderness, and do a percussion test on the spine. So just tap on the spinous processes and see if it elicits pain in a very specific area. And then of course you measure muscle strength. So the patient might not be aware that they are neurologically declining. There might be very subtle signs early on that you can pick up with just a quick screening of the muscle strength. And then you can also do some movement tests, spinal movement, coughing, weight bearing, if any of these things elicit pain from the patient. So we put together just a few very basic neurological screening tests. So this is specifically for the nursing staff at primary healthcare as well, when they see the patient or the home-based carers, just to do a functional examination of the patient to see if there's anything amiss. So ask the patient to just stand up and sit down on a chair. So see if they have any difficulty standing up, if there's poor control when sitting down, if they need to use the armrest or not, or any other assistance. Well, no. Sorry, just want to go back to that slide. And then with a hand grip, you can just ask them to grip your hands and see if the one side is maybe weaker than the other side, or if both the hands are quite weak. It might be a sign. This was more for cervical spine TB, but still, you can just do a quick hand grip strength test. And then a single leg heel raise, you ask the patient to stand on one leg. They can hold onto the bed because it's not a balancing test. And then you just ask them to lift the heel off the floor. So see if they have difficulty maintaining balance, difficulty lifting the heel off the floor, and if there's a difference between the left or the right leg. And then a very general gait analysis or gait assessment. So you ask them to just walk up and down a corridor, just a flat surface without, not an uneven surface. And you just look at their gait pattern and their speed. Look for anything obvious that might deviate from the normal pattern. If there's uneven weight distribution between the left or the right leg, a wide base of support perhaps, if they are limping, any balancing difficulties, do they need a walking aid? No, just want to get back to that slide. Okay. If there's poor control of the hip, knee or the ankle, and maybe if they are walking very slowly because they feel unsafe. And then special tests for spine under observation. You can do a sputum test. You can do an HIV, CD4 and viral load tests, the erythrocyte sedimentation rate, C-reactive protein and platelet counts, white cell count, hemoglobin and alkaline phosphatase, and then MON2 TB skin test, which in TB prevalent countries such as Africa would not unfortunately show anything because it can give a false negative or positive. Sorry, I just feels like there's a slide missing. So I just want to quickly check. Oh yeah, the associated factors. Yeah, so just quickly back to the associated factors. So highly prevalent, spinal TB is highly prevalent in people with impaired immune systems. So you should be suspicious when people come to you with back pain that is not tied to any specific injury or anything like that, who have HIV or AIDS, previous or current pulmonary TB, and just note when this was as well, and if they are on active TB treatment. If there's exposure to pulmonary TB, such as their family members who they live in the house with or are in frequent contact with. If they're living in a TB prevalent country, so if they are living in Africa, that's already an associated factor. Malnutrition is also, as well as alcoholism, drug abuse, smoking, diabetes, chemotherapy for cancer, and anyone with back pain under the age of 20 or over the age of 50. So those are the associated factors. So that's why we do some of these special tests for spine under observation. And then, yeah. So while you're waiting for the test, or if you got the test back and some of them are maybe negative, I'm still not sure, just educate the patient in any case in the meanwhile. It's very important for them to monitor and report their own symptoms. So they should take note of any pain severity and behavior related to their pain. So they must report back on that. any neurological conditions that may develop, so loss of sensation, muscle weakness, pins and needles, a decrease in function, balance, and or gait. If there's new onset of constitutional symptoms, or if any swelling occurs in their back. So they should, this is a very important aspect of spinal TB early detection, is just the education of the patient themselves. And it might also be a very good idea to have this type of education in the waiting room of a primary healthcare facility for family members that might see it and recognize one of their family members as well. But just general community education is a good idea. So conservative management, they usually prescribe orthosis for the thoracolumbar support, dietary support for malnourished patients, physio and occupational therapy to address any functional and neurological conditions, problems, an improvement in general hygiene, and then psychosocial support for the patient. So chemotherapy, so these are the drug treatment for the patient. Standard drug regimes typically consists of a quadruple combination of drugs for an intensive period of 2 months, followed by rifampicin and isoniazid for 6, 9, 12, and 18 months. This is done to achieve bactericidal sterilization. So that's why multi-drug therapy is used. And in South Africa, to optimize compliance, we use the directly observed treatment short course system, the DOT system. And then we have Rifa-4, which is the combination of the 4 drugs in 1 tablet. And during that period, the patient typically receives a financial grant as well. And then surgery, this is the more severe advanced stage options. So when there's severe pain and spinal instability, then surgery is performed. So it's usually when the anterior posterior column is involved and is unstable, and this is done for decompression, debridement, and they usually do a vertebral fusion. So here's a quick look at the tool, but Dr. Tawa will have an in-depth discussion about this. So just how the patient walks into your clinic, or you walk into their home if you are the home-based carer, and you just start by asking the nature of the pain and move on to any constitutional symptoms, associated factors, and just how you go about working your way through this. So we've done a review, and here's where Dr. Nasib Tawa will take over to just have explain to us how, or explain to you guys how we did it.
Thank you, Marisa. And,
you can continue.
Thank you, Marisa. I don't know whether you can hear me.
Yes, we can hear you.
Okay, thank you. Now, just to pick up from where Marisa has left, we're now going to look at the STB review, which we did at the department in Stellenbosch, and this review is what led to the development of the clinical decision-making guidance tool that we are going to also look at very quickly. Marisa, if you can quickly run the slide, because I can't.
Yes.
Thank you. So here, first and foremost, I think it was important for us to have a clinical guidance tool for the primary care clinicians, but particularly coming from evidence from actual patients on the clinical setting. And so we undertook a comprehensive literature search from the month of October 2018 through to March of 2019 this year. And the searches were performed through within the University of Stellenbosch library systems. And we particularly targeted specific databases which we thought would contain the relevant information. So we did a search on PubMed, Scopus, and Google Scholar using specific medical subject terms and combination of the various key terms. Eligibility for inclusion of the relevant studies was established, and we particularly targeted case studies which report on patients with a target condition, which is spinal TB. And in that case, we looked at any case study done within the African continent, or rather globally, which reported on risk factors for spinal TB, or which looked at the clinical signs and symptoms, or those which also looked at the diagnostic investigations as well as standard management for spinal TB. So, of course, we got quite a number of potential relevant studies, but applying the specific or established inclusion criteria, we ended up with a few which met all the criteria. Data extraction, of course, we extracted information from each of the included case studies with regards to the age of the patient, gender, nationality, aspects. Regarding clinical signs and symptoms, the risk factors. So all this information was extracted into an agreeable data capture sheet, and we applied narrative review analysis to come up with the relevant information. So we use the specific critical appraisal checklist, particularly for case study type of studies, to appraise the quality of all the relevant case studies that we came up with. And using that criteria checklist, all the included case studies in this review met had a good quality. So this clinical guidance tool then therefore is an outcome of case studies which met good criteria. Now, we analyze the information extracted from all the included studies using various analytical methods. We began with narrative analysis, then descriptive analysis of the information, which we then developed summary tables. But most importantly, we did factor analysis, which then considers the strengths of the contribution of each of the extracted information into looking at the specific patterns of the risk factors which were linked to the condition. So the final clinical guidance tool and the factor combination is an outcome of the factor analysis which was performed as a secondary analytical method. So the tool which we are going to look at came about after following specific steps. So step one, of course, we had to define the content of the tool. This came after finalizing the factor analysis and the data analysis. Then this also came after doing the development of a framework based on the evidence, after identifying 15 factors, symptoms, physical signs, which are classical to spinal TB, as well as the investigations. And then we included the review, of course, was presented to secondary and tertiary care. Most of the patients, the cases which were reviewed in this paper, actually was seen in either tertiary or secondary care facilities. And therefore, we thought it was important to attempt to extrapolate the applicability and the clinical relevance of this information or the evidence, particularly for the PHC level of care, because the target application of the clinical guidance tool is actually primarily for the primary care level clinician. So the evidence was then interpreted and extrapolated in or with the PHC level in mind. In step two, the reviewers did inclusion of the context-specific information. And these are things which were not included in the case studies as a project. But because we were looking at gathering evidence and to be applied in PhD, we considered adding information which is relevant and specific to the primary care level, which was not reported in the reviewed case study. So we identified relevant gaps, and therefore we particularly looked at linking the evidence to the target context of application. And in this, we therefore, for instance, we realized that we have to consider any patient with back pain to be a suspect case for spinal TB, and therefore these patients need to be referred for gene experts sputum analysis for as a confirmatory diagnosis for spinal TB. And of course, considering the severe burden of spinal TB in the South African clinical context, its potential and the potential severe debilitating effects as well as the cost implication, it was deemed necessary to ensure that we have something which is of high value but less cost with no harm benefit. So, of course, South African context with a high HIV, TB burden and patient education and case monitoring was also considered to be important. And so all these factors were considered in the content and the logical flow of the clinical guidance to ultimately. In step 3, therefore, the reviewers, we did draft the clinical guidance tool, and the content of the tool was primarily targeted for the PHC nursing staff and clinicians. This is because these are the people who come into contact, or rather come into first contact with the patients with spinal TB. And the management principles of TB used in the nursing staff at this PhD level is actually outlined in the PAC care tool, which was of course also incorporated and considered in the clinical guidance tool. And we consider the frequency of symptoms since most, at least except 3 of the recorded symptoms of the cases, all the other out of the 14 cases which were reviewed, only 3 did not present at the secondary or tertiary care level with back pain. And therefore, for this particular reason, the tool that we're going to look at begin with the case of a patient with back pain, either be it cervical spine pain or thoracolumbar pain. So the tool begins with a patient presenting with a PHC clinician with complaints of back pain. The information was then logically organized to ensure ease of compliance, to ensure that the different cadres of primary health care professionals can easily follow in their clinical decision making, aimed at early detection of spinal TB. Step 4, we thought it was very important for us to have consultations with experts in the field, and therefore the tool, or rather the draft tool, was evaluated. We invited 2 practitioners at the PhD level. This included a family physician and a registered nurse who made very significant substantive contributions to the tool. This was meant to ensure that the tool is user-friendly and it relates to the level of care and the target colors that we are looking at. So thank you, Marisa. When we look at the tool itself, so this is a pathway, a decision-making pathway for the PHC clinicians.
Hello?
Okay.
Hello, doctor?
Yes, can you hear me?
There's a lot of background noise. Is it from your side?
You can hear some background noise?
Yes. Is it from your side or is it from one of the other participants?
Maybe one of the other participants?
No, because I think everyone is muted, so it should be somewhere there. So, and also, Dr. Tawa, can you just speak a little loud?
Okay, can you hear me now?
Yes.
Yes, but you need to just check on the background noise at your side, please.
Okay.
Is someone talking in the background?
Yes, there's somebody in the next
Can you please?
door.
Yeah.
Is it so disruptive you can't hear me now? Sorry. Hello?
Hello.
Can you hear me now?
Loud?
Yeah,
Can you hear?
I think that's going to be better.
Is it better now?
Yeah.
Yes, much better. Thank you.
Okay, thank you. So as you see on the clinical guidance tool, as I was talking about, the pathway begins with the patient presenting to the clinician, whether with complaints of neck pain, thoracic pain, or low back pain. And therefore, the first thing that the clinician needs to do is to check the history and the nature of the pain as reported. And it's either way, it could be history of an insidious gradual onset, or it could be history of trauma. Regardless of the two, so that such a case can be, or rather should be, considered as a suspect of spinal TB. And then the next step, as you can see the arrow on the left, you assess if this patient presenting with spinal pain, do they have any of the non-constitutional symptoms as stipulated in box C. And the constitutional symptoms that Marisa was talking about is fever, complaints, or reports of night sweat, weight loss, significant weight loss, which cannot be explained, and so on. And if the patient has back pain, insidious or traumatic, but has, if they do not have any of the non-constitutional symptoms, then of course that can be suspected mechanical spinal pain, and they should be referred for physio or conservative management. However, this patient needs to be monitored for 6 or so weeks. If there is no improvement, then a relevant decision is made. On the other end, if the patient with spinal pain has the non-constitutional symptoms, then you quickly need to assess for the associated factors. And these, as Marisa presented earlier, these include if the patient is HIV/AIDS, do they have diabetes mellitus, do they have concomitant pulmonary TB, or having lived or exposure to PTB and so on. If yes, this is a candidate who needs thorough comprehensive physical examination to identify at least one of the non-associated signs, and these are the paraspinal pain, or the spinal abscess, or obvious spinal deformity. If the same patient with associated factors with at least one of the signs, then again you conduct a neurological screening, as Marisa explained. And if they are positive on both, or rather in associated factors, associated signs and symptoms, and with a neurological screening, then this is a patient who needs to be referred for surgical review for possible administration. And the other guidance, as you can see on the towards the right, if they have no associated symptoms, then you quickly consider investigation, and we recommend the gene sputum sample. X-ray can be taken, and if it's positive, of course, prescription or commencement of standard chemotherapeutic management of TB, as Marisa mentioned, the prefer-4 combination regime, and monitoring of the progress of the patient. So this is a very simple, easy to use, and user-friendly clinical decision-making pathway particularly for the primary care practitioners, which they can use to screen patients who present with any form of spinal pain in order to detect whether or not they have spinal TB. And I think the tool down, you can see that we have provided all the information in the boxes to complement the tool. So we thought of providing or sharing with you hypothetical cases to try and work, rather apply the tool and see how we can go through the decision-making process to the end. So, for example, case one here, we have a case of a 46-year-old female with a new onset of low back pain for about 1 month, which has been slowly increasing in severity. And there was no specificity that the patient can relate to. But the patient is history of family. She's married with 4 children between the ages of 4 and 10. Her husband works within the mines in Gauteng, and she's now unable to do her housework because of the pain. The children are attending school at the moment, and they're too young to assist with house duties. So these are some of the typical cases that primary care clinicians encounter in day-to-day practice. And so the guidance, by following the logical pattern within the guidance tool, this can lead a patient, rather a clinician, into making the correct and accurate decisions. So for such a case, then you simply apply the clinical guidance tool and say, this patient, of course, is presenting with back pain. So, of course, we say any spinal pain patient is a suspect for spinal TB. So you look, the first thing is, where do we start? Of course, you assess, does this patient have any of the constitutional symptoms? If yes, and from the history of the information given here, the patient does not have any of the constitutional symptoms, then you assess.
Hello, doctor, sorry for stopping you again. It's really difficult to hear you with the speaking in the background.
Sorry, can I ask Marisa?
Yeah.
Yes.
Are you in a quiet place? Because
yes, we will continue with this, and then you can mute your mic. Thank you.
Okay, thank you.
Okay. All right. So we have, for our case here, we have a 46-year-old female with new onset of lower back pain for about 1 month, slowly increasing in severity. There was no specific incident that she can remember that related to the start of the pain. She is married with 4 children between the ages of 10 and 4. Her husband works at the mines in Gauteng, and she's now unable to do her housework due to the back pain. Her children are attending school and are too young to assist with any of the housework. So, what would be the first question you would ask her? So during this objective interview, she states that she does have an appetite. So that would have been any constitutional symptoms that she might have. And then the next step would be to ask or to look at any associated factors. We asked her, and she said she's HIV positive and on ARVs, but the ARVs are not always available at the clinic. She doesn't have any other comorbidities. So once again, you move on because she does have one of the associated factors. And she lives in South Africa, which is a TB prevalent country. So next.
Thank you, Marisa. I'm back,
yes.
Sorry.
Oh, yes.
Wonderful.
That sounds great.
Is it clear now? Sorry, I'm very sorry for that. Some people were making phone calls next door. Yeah.
You're perfectly clear now.
Oh, okay. So again, the question, are we still on the first case, Marisa?
Yes. So
okay.
It was the 46-year-old female.
Yes. So and next slide.
Mm-hmm.
Yeah, so the first thing is, of course, we would ask for the history, and in the history, she's HIV positive on ARVs, but not always available at the clinic, and no other comorbidities. She lives in a TB prevalent country, and these are some of the known, associated risk factors which Marisa was talking about earlier in the presentation. So then we have to ask, what would you then, or rather the clinician, assess? We are going to do assessment to see whether she has any of the known associated signs. Thank you. So she pointed a finger with a finger to the lower lumbar spine to show where the pain is. As Marisa mentioned earlier, patients with spinal TB, they'll be able to particularly point the area of pain with one finger, as opposed to showing the area of symptoms or signs, the area of pain with their whole hand. And therefore, this shows the localization of the spinal TB related spinal pain. Upon physical exam on this patient, there was tenderness or paraspinal tenderness around her lower spine on palpation, and she struggled to bend forward and touch her. So as you can see on this particular patient, she's got the associated factors, which we have talked about earlier. She's also got some of the, at least one of the non-physical signs on examination. So the next then would be to assess if she's got any neurological deficits. The patient is unable to stand, or rather is able to stand up and sit down in the chair and in a controlled manner, and she could perform left and right heel raise. And therefore this shows that the patient, and when you look at the other information on her neurological screening, her hand grip was satisfactory on both sides. There's no discrepancy and she could walk. And therefore this particular patient, if you recall on the clinical guidance tool, she's got spinal pain, yes, history in living in a prevalent TB prevalent country. She's HIV positive, and therefore those are the non factors. She's positive on the physical signs for spinal TB, but she's negative on the neurological screening. And using the pathway, you can see exactly where this patient, or what kind of decision and actions the primary care clinician will be able to take on this particular patient. So she's been positive on all the aspects, from spinal pain, presence of constitutional symptoms, but then she's turned out negative at the screening for neurological manifestations or neurological deficits. And therefore, the next step for this particular case will be to request for a sputum sample for examination to see whether, and you can see the information is that the results from the sputum sample that was taken from this case came back positive. Now, while she's negative on neurological examination, she's got a positive sputum examination, and therefore commencement of the standard chemotherapeutic management of TB would be commenced on this case example number 1. So if we follow the stepwise protocol or the stepwise pathway from the patient presenting with spinal pain, we would at this, for this case 1, we would end up at having the patient commenced on the standard chemotherapeutic management for STB, which is the standard 4 drugs, or the initiation of the DOT regime for, as used in the South African clinical context.
Yes, and also she will also then be monitored and educated alongside that to make sure that the symptoms do not progress. So she she will be a spine that's being treated,
and
but very
monitoring.
Yeah,
very correct. And again, we here, just to show the other side, other possibility that the primary care clinician can, encounter in practice. We have a case 2 of a 6-year-old male with back pain since 3 months ago. He's not had any previous problems with his back pain. He noticed the back pain after he fell while fixing his veg garden fence. He lives with his wife and 2 children, or rather grandchildren. Both he and his wife receive pension and child support for the 2 children. His wife was diagnosed with PTB 6 months ago and has been adhering to the standard treatment. Now, different from case 1, this particular patient, case 1 and 2, they both present with spinal pain, but they vary in the nature of the history. Case 1, there was no history of trauma. Now here we have a case of trauma. Although just because the patient has a case of, there's a history of trauma does not necessarily negate the possibility of spinal TB, because we've seen cases where a patient is diagnosed with spinal TB after, even with having a history of a minor or trivial, trauma. So same question as in case, case study 1, what would the primary care clinician ask first? Of course, you have to check whether the patient has any of the non-constitutional symptoms. And these, as Marisa was mentioning earlier in the presentation, these include the fever, night sweats, loss of appetite, weight loss, and cough, significant weight loss and cough. So you check whether the patient has any of the non-constitutional symptoms associated with spinal TB. And then the next step, Marisa, would be to, if they do not have any of the constitutional symptoms, then you can see in the decision-making tool that this patient, considering the history of trauma, this patient will be referred for physiotherapy or conservative care, physiotherapy, and of course monitoring of the symptoms within 6 weeks. But for this particular patient, when he was referred for physio, the physio did examination and picked up no danger signs, and therefore treated the patient for mechanical back pain, plus additional back care education, and sent the patient home with a prescribed exercise program and follow-up over appointment. Now, for such a patient, if the symptoms with physiotherapy, back care program, and prescribed home self-care program, you expect symptoms of mechanical back pain to resolve within at least 6 weeks. If there's no improvement for this patient, then of course they have to be reevaluated or consider conducting other examination to rule out the possibility of spinal TB. Because as I said earlier, just because the patient has a history of trauma does not necessarily negate the possibility of a spinal TB patient. And of course, the next slide, as Marisa had quickly shown, this is the publication which came out, I think, this week, two or so days ago, Wednesday this week. And this is the outcome of the review which we undertook, a publication. And of course, the most important bit of this publication is the clinical guidance tool targeting primary care practitioners, aiming at screening for early detection of spinal TB, because the ultimate outcomes, if we miss it out, then the resultant manifestations, of course, of debilitating disability, tetraplegia, paraplegia, and many other complications. So we're hoping that this publication and, of course, the resultant clinical guidance tool will be, cascaded downwards to the targeted primary care clinicians in South Africa to ensure that it is rolled out for, adoption and application to enhance early detection of spinal TB, which seemingly is on the rise in our context.
So that was the last slide.
Dr. Tawa, thank you, and Marisa, thank you very much. I think that was really eye-opener to hear what you did and how you did that. And are there any questions with regards to the methods that were taken, the clinical tool, and also the case study?
Questions from my end?
No, from the other participants that are online.
Thank you.
Anyone with questions, please raise your hand, or so we can open up the thing, or you can post a question online. None so far.
So there was a few questions that came in over via email, Marisa, that I sent to you a little bit earlier. But maybe I can raise them and you guys can discuss it. I'm not too sure if the individual who sent in the questions has also joined in today, but for the recording, maybe it would be helpful to have. One of the questions were for imaging differential diagnosis TB and non-TB spondylitis.
I think we should answer that question by email. It's I think I've seen these questions,
Yeah.
and I think that maybe if we can respond to the group by email on this, because it is not really questions that you can just answer out of hand at the moment.
Very correct. I agree. I think we can give a substantive response or clarification on that by writing, if through the communication that Marisa and the team has had. So we can do, we'll look at the question clearly and put up a response to the team.
That's a good idea.
Sure.
Good.
Niraj, from your side?
None, that was very clear. So I think that's good.
Yeah, I think in general, the presentation went well, and we are happy with what the contents is. If you've got anything that you guys think that we need to add to this, it will really be helpful. And if you can maybe think about that and correspond with us with regards to the contents, it will be great. We are glad that you guys joined. It's a pity that we did not have more people, but I think it's also as we discussed with the time change.
The time is not the best timing.
And holidays and all those type of things. But and in South Africa at the moment, I was just thinking we have got our World AIDS Day coming up, and a lot of the people were involved in that. But we hope that we'll have a lot of people that will join this course. And thank you very much for attending. I think that most of the questions and questions were answered and information was shared.
Right. Thank you very much. So I will plan to have another follow on this maybe early January or so, or after the holidays, mid to late January.
Yes, we'll be in communication with you, and we'll see how we can set up a program on how we can do this, and with regards to South African times and the challenges that.
So, Shar, we're going to send this out to everyone, right?
The recording will be sent out to all of the attendees who registered. It will also be available.
How many had registered?
We had 33.
Yeah, so which is good. So we'll send it out to everyone by Monday next week.
And they're also available on tb.academy. The recording will be available on tb.academy.
Okay, wonderful. That's great.
Yeah.
Right, thank you so much.
Thank you, Sharon.
Thank you so much.
Bye-bye.
Thank you. Bye.
All right. Bye-bye.
Okay, bye.